Hi, I'm Dr. Lauren Jancy, and I'm an associate professor at the Johns Hopkins University School of Medicine in the Department of Pediatrics. I am also a neuroscientist in the Johns Hopkins Children's Center, and I am so pleased to be able to tell you about our recent work that was motivated by clinical reports of the increasing use of antipsychotics in preterm and term infants in NICUs across the country. These medications are being used or are being proposed to be used, along with others like opioids and clonidine, to treat agitation and delirium like behaviors in sick infants. Delirium is well characterized in adults and is typically thought of being an acute neuropsychiatric disorder with significant disturbances in attention, awareness, and cognition without a previously diagnosed cognitive impairment. Other groups have suggested that neonates are untreated for their delirium because of a lack of awareness about what delirium is. However, in the rapidly developing brain that is frequently subject to the impact of comorbidities and multiple illnesses in our units, the identification of an acute cerebral disorder and the exclusion of cognitive impairment, both essential diagnostic criteria for delirium, are challenging. While these established and common diagnostic and treatment protocols exist in PICUs and adult ICUs across the country, more information is needed to understand the state of the science in the NICU patient population. We need to understand how medications like risperidone and quetiapine affect a rapidly developing, immature, and injured brain. Thus, in my lab, we wanted to test the effects of administering antipsychotics like risperidone and quetiapine on the developing brain in a preclinical model of perinatal brain injury. We hypothesized that administration of antipsychotics in the neonatal period would perturb the development and establishment of neural networks, change neural connectivity and brain connectivity as a whole, and enhance the pro-inflammatory milieu with long-term consequences to brain function. We administered risperidone during preterm and term equivalent developmental stages. We found that risperidone administered in the preterm period yielded large global increases in functional connectivity in the thalamus and association areas of the brain. In contrast, risperidone administered at term age induced large focal increases in sensory motor, cortical, and cortical basal ganglia connectivity. Risperidone also caused ataxia and hypomobility. These changes were also found to co-occur with increases in pro-inflammatory biomarkers and immune system activation. In conclusion, we found that risperidone significantly changed brain structure and brain function. It increased systemic biomarkers of inflammation and caused immune activation. These results suggest that administration of antipsychotics after brain injury impair neurodevelopment and cause immune dysregulation. These data provide a basis for further scrutiny to ensure safe and appropriate use of antipsychotics in neonates. I would like to thank the entire Jancy team here at Johns Hopkins and all of my colleagues in the NICN unit here. Thank you so much.